to 80% of women will have fibroids in their lifetime. Super common. Fibroids are benign tumors. Black women have a much higher rate of fibroids, and we don't really understand why. It's been linked to potential vitamin D deficiency and things like that, which is really interesting. And they can cause really heavy periods, pelvic pressure and pain. And if they're on the inner lining, they are a cause of infertility and pregnancy loss.
Fertility is a huge topic. Many have claimed that we're in the midst of a fertility crisis. What would you say are the biggest mistakes that people make that is negatively impacting their fertility?
Well, I think it's...
Do you think all men should consider freezing their sperm at a certain point?
I think is a great technology, and a lot of people do consider it and do it successfully. And if I was a man and I knew there's a chance I might be having kids at an older age, I definitely would do it just as a contingency plan.
For women, does putting your legs up after sex help with fertility?
No, you can hop out of bed right away. It's not going to affect the chances. Those sperm cells are going to go where they need to go. You don't need to sit there for an extended period of time. This has been studied as well.
Very interesting.
I think that people would think twice before vaping or smoking if they really knew that it can put you into menopause earlier, especially smoking. We have a lot of data on that. And we know that it can affect egg quality. It can affect the ability to get pregnant. Obviously, we know it's really bad for pregnancy.
Dr. Lucky Sekhon, welcome to the show. How you doing?
I'm doing great. Thank you for having me.
It's great to meet you. Where are you in from? You're in from New
York
City. I love it. That's where I'm from.
Oh, I didn't know that.
Yeah, born and raised.
When did you move?
About 20 to sound like a dinosaur, 20 years ago-ish.
Okay. Any looking back? Do you think you'll ever come back?
I don't think so. I like visiting, but I couldn't deal with the cold, the winters and the stress.
Yes, that is a current issue.
It's
really nice to be here, even if it's only for 48 hours.
Well, welcome. I'm super excited to talk about the topic of your new book, The Lucky Egg, the subject of your expertise. Fertility is a huge topic. Many have claimed that we're in the midst of a fertility crisis.
Yeah.
So let's dive right in. What would you say are the biggest mistakes that people make that is unknowingly negatively impacting their fertility?
Not focusing on it early enough, right? Kind of maybe having a level of complacency. It's because there's so many things that need to be in place in your life. Like, depending on the person, a lot of people want to find the right partner in the right situation. They want to be financially stable. And so it's very easy to say, okay, this is going on the back burner and I don't even want to think about it. In fact, thinking about it makes me feel anxious. And so it's just not something that's top of mind. And then when it does become top of mind, it can be difficult for many people if they're at a point in their lives, specifically when it comes to female fertility, where their egg count might be lower or the egg quality may pose as an issue. So I think everyone should be talking about this earlier and prioritizing, at least thinking about it and having an awareness so that they can make informed decisions.
And how might awareness of one's fertility show up in terms of the lifestyle decisions that they're making, maybe the dietary decisions that they're making?
Well, I think it's on multiple levels. Yes, I think that people would think twice before vaping or smoking if they really knew that it can put you into menopause earlier, especially smoking. We have a lot of data on that. And we know that it can affect egg quality. It can affect the ability to get pregnant. Obviously, we know it's really bad for pregnancy. This is something that I'm seeing a lot of Gen Z not being aware of. And I think if they were thinking long-term, like what are the day-to-day habits, nicotine, smoking, that we know can have a really bad effect on your fertility, they would probably think twice, right? Mm-hmm. When it comes to diet, I think, yes, we know diet affects fertility. I think whatever's better for heart health has been proven to be better for fertility. So if you're kind of focusing just simplistically on what do I know is good for my body as a whole, it's going to put you in the right direction in terms of thinking about your fertility long term. But there's a double-edged sword here, because it's not to say if you do all of the right things and you're taking care of your heart health and you're not smoking, you're exercising, that you're immune to the biological clock. So there's this element of timing, genetics, biology, and then layer on top of that the effective lifestyle, which does have an effect. But it's not always going to be 100%. It's not going to be 100% protective. Let's put it that way.
Interesting. So what's good for the body generally is going to be good for fertility.
Yeah.
Are there unique considerations? Like if fertility is something that's really important to you, prioritizing certain, foods that contain nutrients that we know or that we suspect are beneficial, like oysters. Everybody says oysters are good for fertility.
That's so interesting. I never hear that actually.
Really?
And I haven't really seen any data on that. So I think that's more of an old wives' tale.
Probably.
An antioxidant-rich diet, right? That's always going to serve you well. When you think about the wear and tear of aging, specific to how it affects our biological clock, you have in the background just the machinery that breaks down in our eggs, right? And our eggs have chromosomes. They have packages of DNA that are basically filed away. Imagine you have these proteins called cohesins that act like filing cabinets. That breaks down with age and there aren't any repair mechanisms, right? And I always think of it as like a factory where the chromosomes in each egg cell are being like lined up and there are no repair mechanisms for the machinery. And so on the assembly line, things can become disorganized and you can have chromosomal errors where an egg gets ovulated and fertilized and it has missing or extra DNA. And if that turns into an embryo, that's an embryo that most likely won't implant, or it might implant for a little bit and then stop growing. That's the number one cause of miscarriage in the first trimester, right? Now, aside from that machinery breaking down because there's no repairman coming to fix the machinery in the factory, if you think about external influences on egg quality and fertility, think about things like insulin resistance, cigarette smoking, toxins, as being akin to turning the heat up in the factory or turning the lights low. So it's like now there's even more errors happening. And those are modifiable things that if you take them away and you fix those things, that you may have less errors, but that wear and tear of aging is always in the background. Does that make sense?
Yeah, so it's there, but it's harder to reverse once it's seeped in.
Correct. We don't know how to reverse the effects of aging when it comes to our biological clock, but certainly there are behaviors like an antioxidant-rich diet, and there are certain antioxidant supplements that have been looked at, like coenzyme Q10. And there is this idea that, well, at least I'm not adding to the picture of how things are deteriorating over time, right? And, you know, a lot of women have insulin resistance. A lot of men and women have insulin resistance. And we don't really truly understand, is the prevalence increasing? Is our awareness increasing? We see a lot of women with polycystic ovary syndrome that happen to also be insulin resistant. It is way underdiagnosed, and it is a major problem. Not only can it negatively impact our egg quality and our ability to get pregnant and stay pregnant, it can also impact the environment that an embryo is trying to implant into. And so it creates this pro-inflammatory situation that is reversible. You know, the way we eat can change the way we process blood sugar. It can change our insulin spikes if we're pairing carbs with protein and fiber, right? If we are building muscle, that automatically makes your body more sensitive to the effects of insulin. And this isn't a moral failing. This isn't something that, oh my gosh, you're not eating right or you're not, doing enough activity. This is sometimes just genetically how we're wired. And sometimes it's an environmental rewiring that happened maybe when you were a fetus in your mother's womb. There's so many different theories as to how this develops.
Wow. But I mean, what you said is just so crucially important, that building muscle and maintaining a strong, robust, vigorous body isn't just about how you look in the mirror.
Correct.
It's about, fertility. It's about systemic health. It's about metabolic health.
Yeah. Body composition really matters, especially when it comes to insulin resistance.
Wow. The whole resistance training to fertility axis is not something that I'd previously considered. It's fascinating though.
Yeah.
So cool. You've talked a bit about biological clocks, and I think most people, when they hear that phrase, they think about females, but do men have a biological clock?
They do. It just ticks differently, right? So men are always making new sperm. Every 74 days, a new sperm cell is generated, and there's millions of them. So it's not that same scarcity factor that women have. We're born with all the eggs we're ever going to have. We don't make new eggs and we don't repair our eggs. So both egg quantity and quality decline, not in a linear fashion. So it's not always predictable. But the typical pattern is that these changes tend to speed up as we approach 35 and over. That's why everyone freaks out about turning 35. But it's not that you're falling off a fertility cliff. It's that we know that these changes are becoming more drastic. For men, there isn't really an agreed upon definition of what advanced paternal age is. There are some studies that suggest 45 and older. There are others that suggest, okay, if you're in your 50s, that's considered advanced. And the effects and associations that come along with that really are more focused on, okay, there's an accumulation of mutations as a man ages, and those can be passed on through the sperm DNA to their future children. So there have been associations between advanced paternal age and an increased incidence of certain neurodevelopmental disorders in children. Autism has been linked to advanced paternal age. Obviously, it's so multifactorial, and that's a very controversial statement. But there are multiple studies that have found this potential association. And it's not even just about age. Male health behaviors and the controlling of chronic medical conditions not only can impact their partner's ability to get pregnant, but also they contribute to how the placenta forms. The placenta is this magical temporary organ. It basically gets built between 7 to 10 weeks of pregnancy. Its main function is to connect blood circulation from mom and baby as the baby's developing. When things go awry with the placenta, that is a major cause of many different types of pregnancy complications, like preeclampsia. That's basically where a woman in pregnancy gets high blood pressure because there isn't enough blood flow getting through the placenta. So it's a way to compensate for that. Your blood pressure goes up to push more blood flow through, right?
Wow.
All of these types of issues that stem from placental issues have been linked to male health habits, chronic medical conditions, sedentary lifestyle. And this is why when I speak to couples in my office, I'm always saying to both couples, like, what is your lifestyle? Like, what is going on with your health? What are the things that we could be working on? Because both partners really need to come to the table and bring their A game if they want to put their best foot forward and know that they're doing everything that they can.
Wow. Could you speculate as to the mechanism by which like male sperm quality might influence the placenta's ability to adhere?
There's a lot of paternal genes that have been implicated in placental function. So it's people often think once the sperm fertilizes the egg, that's the end of the story, but that's not true. Anyone who's gone through IVF knows all too well that human reproduction is inefficient, and a lot of eggs that fertilize normally, seemingly, are incapable of turning into an embryo, which takes about a week. And a lot of the drop-off happens beyond the day 3 stage. And a huge part of that is egg quality, but there's a major contribution of sperm. And that's why one of the things that we will focus on if someone has an unexpected rate of high attrition where none of the fertilized eggs grew into embryos or a very small proportion, I'm not just trying to look into egg-related factors. Oh, could there be uncontrolled or unrecognized insulin resistance? Are there things we could be really fine-tuning there? I'm also focusing on sperm and saying, hey, maybe we need to sort the sperm differently in the lab and be stricter with the selection of the sperm that we're using. And also, I'm always kind of going back to the male partner and thinking, what can we optimize about your health or your habits? Like, could it make sense that you need to take a little bit of time to institute changes because we know that it takes 2 to 3 months to kind of turn over that pool of sperm.
Are you, when zooming out and looking at public health statistics, does it concern you as a fertility expert that, so many people today are struggling with metabolic illness, with overweight, with obesity, with insulin resistance, with type 2 diabetes, with prediabetes?
Yeah, I think it is really hindering a lot of people's fertility. And it's a delicate conversation, right? Because especially with overweight and obese patients, there's a fine balance. We're talking about this biological clock, and the question is, how long do you take to try to optimize those things? And all the while, there's the wear and tear of aging and how many eggs you have and the quality. So it's this balancing act. This is where I have seen a lot of success, and I'm not saying it's a one-size-fits-all solution or it's for everyone, but I do talk to a lot of my patients who are in that struggle where they're trying to weigh how quickly they should move towards treatment, but should they take time to lose weight because they know that that is a potential risk factor for less than optimal outcomes. I talk to them about things like GLP-1 agonists, in addition to obviously all the lifestyle things, because we are in a bit of a race against the clock, especially in older patients like late 30s, 40s. I don't want them to spend too long grinding their gears. And listen, it's not easy to lose weight. And even when you're doing all the right things, some people are metabolically wired in such a way that it's just not coming off no matter what they do. And I have found immense help in when I partner with medical endocrinologists. And if it's the right thing for the right patient, it does accelerate their ability to lose weight. It does help them address the insulin resistance in a more robust way, in my experience.
At what point should couples seek professional expert guidance in their journey?
Well, the guidelines say based on your age, right? I don't think there's a right or wrong answer, but in general, because human reproduction is inefficient, right? You ovulate 1 egg each cycle, which, if you have a regular cycle that's typical, then maybe it's like once a month, 1 egg. Not every egg is going to fertilize, turn into an embryo. It's like pulling the lever of a slot machine and hoping for everything to line up. So at best in your 20s, you're looking at a 20 to 25% chance each month. So it would be bad advice to be like, oh, try once and then go straight to the fertility expert, right? If you're under 35, particularly in your 20s, I would say you have time to kind of play the slots and say maybe you try for up to a year, right? Now, that advice does not apply if you're someone who never knows when to pull the lever because you never know when you're about to ovulate. Your ovulations are irregular or absent, then you should go straight to the fertility doctor because you don't even know the right window to try, right? When you release that egg, it only lasts for half a day to a day. So if you don't know when that egg is being released, you're probably missing the window. You're not in the game. If you're 35 and older, or even approaching 35. Honestly, like if a patient comes to me at 34, I'm not like, oh, well, the guidelines say come back in 6 months. You know, what's the difference between being 34 and 35? It's a continuum. But mid-30s, I would say, and older, don't wait longer than 6 months. And if you're in your 40s, I know this sounds alarmist, but it's for good reason. I would go see an expert after 3 months of trying.
After 3 months?
Yes.
Super interesting. At what point should all men, do you think all men should consider freezing their sperm at a certain point?
I think if a man thinks, hey, I've got a busy career, I've got all these things going on, or I'm nowhere near finding the right person to do this with, and I think it's realistic or possible that I could find myself over 45 fathering children. It's not an official guideline. There haven't been studies to look at this at a population level, but knowing what we know, that there is a male biological clock, knowing that providing a sample of sperm for the average patient, you know, it's something they do recreationally on their own anyway, and we're just asking them to aim into a cup, right, to be frank. And it's cheap. It's not the same level of expense or invasiveness as egg freezing, which, you know, that I think is a great technology, and a lot of people do consider it and do it successfully, but it's so much easier to freeze sperm. So to me, it's like low-hanging fruit, and if I was a man and I knew there's a chance I might be having kids at an older age, I definitely would do it just as a contingency plan.
Yeah, I actually about a year ago froze some of my swimmers, and I have the semen analysis here with me.
Why did you do it?
Well, it actually was not about, well, I guess it was kind of about a fertility concern. I had spine surgery. Mm-hmm. And one of the potential complications of the surgery, because they take an anterior approach, mm-hmm. was that in a very rare percent of cases, you get what's called retrograde ejaculation.
Yeah, I have patients with that.
Really?
Yeah.
Maybe you could explain what that is for listeners.
Yeah, so it's just basically, you know, the process of getting an erection and ejaculating is all about the nerves, right? Your parasympathetic and sympathetic nervous system are involved in that process. And so anytime someone is having certain types of surgeries, like one big one that I've seen cause issues is when people are getting like lymph nodes dissected. The pelvis is like, you know, there's so many nerves and everything and vessels running through that area in a small space.
It's like Union Square in New York City. It's like the crisscrossing of like
I'm glad you didn't say Times Square. So you're still a true New Yorker.
There we
go.
But
yes, it is very much a possibility where you could have, you know, things go wrong in that process that don't, and also anything anatomically that alters, you know, the normal chain of events. You could end up ejaculating retrograde, meaning it's supposed to go out of the urethra, but it actually ends up going backwards and ends up in the bladder. And so you can still get pregnant. We can collect sperm from a urine sample, believe it or not. We alkalinize the urine sample and isolate out sperm, and we do that for IVF. But it's just easier if we have frozen sperm if you end up needing to do IVF, you know, if you're trying to get pregnant and it does end up being a problem. So it's good advice that you froze.
Yeah, so I froze. It didn't happen to me. Mm-hmm. I didn't develop retrograde ejaculation, thank God. Although it does, it like corrects itself in the procedure that I had in the majority of cases anyway over time. But yeah, so I guess as par for the course, they did a semen analysis, and I'd love to get your analysis.
For sure.
On it. So here we go.
You know, this happens when my husband and I go for drinks with other couples, by the way.
Is it what happens? They pull out their iPhones.
So this is, people are like, can you look at my sample? I'm like, sure. Right after I order my drink.
All right. So I feel less awkward about it.
No, you should not feel awkward. This is what I do every single day. I look at these reports. So.
How am I doing, Doc?
Okay. I would say overall, this is looking pretty good. And I'd give you an A+. This was from when? Let's look at the date. This was from exactly just over a year ago. So something to know about this is if you were coming to me as a patient for any reason, I would probably have you repeat this just because a year is enough time for all of that turnover where the quality can change. So one static time point doesn't necessarily tell me about what your current situation is, but there's no reason to do this testing right now if you're not trying to get someone pregnant and running into problems. But that's just a PSA that like one normal semen analysis 3 years ago doesn't necessarily mean there isn't a reason to retest.
Got it. Quick question. Are there consumer level tests at this point, or do you have to go into a clinic? I mean, we've got all kinds of at-home testing now sprouting up on the market.
Well, there are at-home tests, and they're really innovative. Like people will put a sample and they use their like iPhone camera. It's very cool. I would never use that to make clinical decisions. But it is nice to know, hey, I know you have sperm, right? Because when a couple comes to me with infertility and they've done no testing, I'm not assuming that the male partner is not making any sperm. But every once in a while, we're like, oh, I wasn't expecting this result, and this is like a drastically low level. So it's nice to know when someone's like, I did this at-home test, and it showed that my sample was normal. I'm like, great, at least I know he makes sperm, but I'm not convinced until I have a proper validated way to assess it. So you don't have to go into a clinic. I mean, there are plenty independent labs that will allow you to run this. Sometimes you need a prescription. It just depends on your insurance.
That makes sense.
Overall, this is a great sample. So the four major things I look at, one is volume. And if the volume is low, that could signal that there are blockages, right? Like in the ducts, or even things like retrograde ejaculation. So your volume was 1.3. I'm allowed to talk about this, right?
Yes,
okay.
yes.
Okay, you're giving me full permission?
Consent, yes.
Okay, good.
No HIPAA violations here.
And for this lab, they always have their own set of reference ranges. But in general, like 1.3 to 1.5 is normal. That's what you want. The concentration is one of the biggest things that I look at, and yours was 167 million sperm per milliliter of sample. You can give yourself a pat on the back. Anything over 25 million per milliliter in their lab is normal, but in general, I usually tell patients like over 20 million per milliliter. That tells us that you're making the machinery in the testes. You know, the factory is producing sperm at a normal level. So that's great. The other major one that I think matters just as much as concentration is the motility. Motility is basically a percent of the sample that you're viewing under the microscope that's swimming in a forward direction. And it is a surrogate marker for viability. So if I see really low motility or 0% motility, we do specialized tests then on a second sample, to confirm this finding, because this could have been someone, brought the sample in from home and it was not kept appropriately. It was too hot or too cold, right? You never trust one sample. That's my other PSA. Always get a repeat.
How does sperm know which way is forward? They got like GPS or what?
They have
sperm
so
Google
it's the
Maps?
The tail.
Huh.
Yeah, and the tail is powered by mitochondria. And so the tail is kind of like, it's called a flagella, and it basically goes like in this sideways manner, and it propels the sperm head forward. Yeah.
Amazing.
Things you never think about, right? But the motility matters. It doesn't have to be perfect. Normally we say like 40% of the sample should be swimming in a forward direction. If it's low, though, we can do specialized tests that actually indicate whether they're just immotile, they're not moving, but they're still viable, because then you can still overcome that and inject sperm directly into the egg with IVF, which is kind of interesting. And then the fourth thing, which in isolation is less important, but we look at it at the sample as a whole, is the morphology. And this is what percent of the sample is shaped normally. And depending on the criteria being used by the lab, it's either normal if it's over 14% or over 4%. There's different criteria. For this lab, they say over 14% is excellent fertility potential. Yours was 12%, which is kind of like good fertility potential. Isolated low morphology, when everything else looks good, is not considered an independent risk factor for fertility issues. So you get an A+.
I get an A+?
Yes.
Oh my God, amazing. I was kind of actually surprised by that. Well, there are reasons why I maybe was not surprised, because, my diet's pretty dialed in and I've got a healthy body composition. I work out all the time. But then also I like to use saunas and steam rooms a lot. Mm-hmm. And as men, you always hear that you want to keep the family jewels cool. Right.
Well, there has to be an optimal temperature. Sperm are very sensitive to temperatures that are extreme. And so, there's that episode of Seinfeld, Shrinkage. Do you remember what I'm talking about? No? Oh, maybe you're not a New Yorker. No. There's this reflex that happens where when men are cold.
Well, I'm very familiar with that.
Yes. So there's an episode of Seinfeld where George gets out of a hot tub or something, and then a woman sees him. He's like, it's shrinkage. It's not really the size of my scrotal
the landing
area.
gear lifts.
Exactly. Yeah. But basically there is a reflex. I believe it's called the cremasteric reflex. And the specific muscle will contract or relax depending on your body temperature. So your sperm is being produced in the testes, and so when you're really hot, your body wants to get the sperm away from your body to kind of cool them off. And when you're cold, there'll be shrinkage. Like it's going to get closer to your body to stay warm. Isn't that interesting?
Super.
So if you're in a sauna or you're immersed in a hot tub, no matter what those muscles are doing, there's no escape. Like you're in these boiling temperatures. Now, one off here or there, because I've had patients freak out. Oh my God, my egg retrieval is in a couple of days. And my husband, I can't believe he went to the spa and did this thing. I'm like, listen, again, there's always sperm being produced, and it's not like they're all going to die off just because you sat in a hot tub for 5 minutes. It's the people that are doing this for like an hour a day, every day, where you might see a drop off in concentration and some of the other parameters we talked about. I've seen severe male factor infertility in professional bikers.
Oh, I mean,
right?
well, yeah, that checks out. That makes sense.
Yeah, because it's just like almost like a repetitive trauma to
Wow.
the area where sperm is being produced.
No bueno. Damn. Is more frequent ejaculation better or worse for fertility?
Yes. When I talk about this with patients, I refer to it as cleaning the pipes, right? You have sperm like being made and dying all the time. And if someone has, is abstained for more than a week, you could have a buildup of old dead sperm. If someone has a lowish concentration, it might be even lower or less optimal for when someone is trying in the fertile window to get pregnant if they ejaculated too recently. So 2 to 7 days is what we've kind of seen. We've looked at our own data in our clinic. I work at one of the biggest fertility centers in the country, and we do thousands and thousands of different types of cycles every year, and we've been around for 25 years. So we have an amazing bank of data, and we actually looked at this and looked at the number of days of abstinence because you report this. I'm sure you reported it for... Did they ask you to report that?
Report what?
Did they ask you how many days abstinent you were before you provided the sample? Because we normally report that data.
Oh, yeah, it's right here.
There
Days
you
of
go.
abstinence, 3 days.
There you go. Where were you exactly a year
3
ago?
days ago. Actually don't
So
know.
yeah, there's a reason that we record that information. And so our data shows optimal range is like 2 to 7 days.
But I mean, as most guys know, and I'm sure most women are at least somewhat familiar with, like the less you do it, the more volume you get.
Yes. Well, that makes sense.
Yeah.
Right? Because it's not what determines volume. There are a bunch of other accessory glands that are basically like producing fluids. And those are just a vehicle for the sperm to get out and get to where it needs to go.
Is the pull-out method effective?
No.
An effective form of birth control?
No, and I'll tell you why. The sperm cells are living cells. They're following chemical signals. So even if you feel like, okay, the majority of it did not stay inside my body, there's always some swimmers getting ahead before you actually ejaculate. So it is not reliable. Of course, maybe it's exposing you to a little less sperm, but it is not a reliable form of contraception.
What I've always heard and believed is that on the first go-around, you are pretty protected. It's the second go-around where the pull-out method does not work and is risky, because you might still have sperm in your urethra from the first go-around. But if you've like peed a bunch of times in between, then it's like, any science to that?
No.
Pseudoscience?
No.
I'm spreading misinformation?
Well, I don't think you're spreading misinformation. I think it's like these are the lies we tell ourselves to make ourselves feel better, right? In certain situations. And these are the myths that are passed from man to man in the locker room, but I'm here to put the
those to
record
rest.
straight. Exactly.
We
Because
love it.
the risk of unplanned pregnancy, no one wants that. So it's better to be safe than sorry.
What about if you are trying to get the job done? For women, does putting your legs up after sex help with fertility?
No. You can hop out of bed right away. It's not going to affect the chances. Because again, the fluid is just a vehicle, and those sperm cells are going to go where they need to go. Those microscopic sperm cells are going to get through the cervix, and you don't need to sit there for an extended period of time. This has been studied as well.
Very interesting. Do IUDs impact fertility? Like, can you freeze eggs while having an IUD?
Yes. Yeah. The worst thing that I hear sometimes is patients coming into me for the first time saying, I'm here because I want to learn about egg freezing. I saw my GYN last week. She took my IUD out. I'm good to go. And I'm like, you didn't need to do that. The IUD is basically this T-shaped structure that sits at the top of the uterus. And unlike hormonal birth control pills or the patch or the NuvaRing, the ring, those work by telling your brain, hey, there's already enough estrogen and progesterone, you don't need to do your job. So the brain goes, okay, great, I'll take a break and not send any signals to the ovary, and you stop ovulating. And that is the main mechanism of contraception there. For the IUD, it's not reliably preventing you from ovulating, but think of it as a bouncer that's like the sperm cannot get to where it wants to go. It wants to go to the VIP fallopian tube lounge, and it's like, sorry, you're not getting admitted. It can't get past the IUD. It also creates changes in the uterine lining, but these are all very reversible changes. And either you have the hormonal IUD or the copper IUD, but both work to prevent sperm transport. That's the main mechanism. The hormonal IUD can make it so that you stop getting periods altogether, or you get them very infrequently or irregularly. And that's just the effect it has on the lining. The copper IUD will not have that effect. In fact, it can actually make your periods a little bit more heavy and annoying depending on the person. Once you remove it, though, that environmental stimulus is gone. And this is an immediately reversible form of contraception.
The copper IUD, so there's no medicine involved? It's just like a physical block?
Right. Correct. It's like temporary sterile inflammation that prevents the sperm from getting to where it wants to go.
I mean, from my non-female, non-expert vantage point, it seems like it seems like that would be the way to go. No systemic like medication.
Yeah, I mean, I think that you have to be okay with the procedure to have it inserted, and that's been a huge area of controversy, right? Because a lot of women haven't been offered the pain control options that they really should. And there's been a whole movement on social media where women have shared their stories about the excruciating pain and the trauma of IUD insertion without any pain management.
Why are physicians not using pain management?
This has been a huge thing. Like, there's been a push to say, you know what, we should be offering, we should not be just saying, take 3 Advils an hour before. That is traditionally what women are told, right? And that is not sufficient for a lot of women. There's something called a paracervical block where you can inject lidocaine into either side of the cervix. And that is actually a much more effective form of pain relief. And you have to do that ahead of time. And I mean, there's been tons of articles written on this. It's like workflow, the way clinics work. It takes time. It takes time for the meds to kick in. But it falls on deaf ears because at the end of the day, it's an excuse. And it's kind of, going based on a longstanding history of women being expected to just suck things up and deal.
Wow.
Yeah.
That's crazy.
So I do think it's a good plug to say, if you are interested, I think IUDs are great. I agree with you because they are long acting as well. It's not like you have to remember to take something every day. So for people who are, living a crazy life, maybe like going between time zones, working really hard, it might be easy to forget a pill here or there and then it's less effective, right? But if you are interested in IUD, I think it's a great option. It's about going to the doctor and knowing what to ask. And I think ask about your pain control options beforehand.
What have doctors typically downplayed the amount of pain involved in the procedure?
Not all, but some. I mean, there's a long-standing history when it comes to how women's health has been treated in the field of medicine where pain has been dismissed. This is why it takes an average of 8 to 10 years to get a diagnosis of endometriosis.
Wow. Crazy stuff. Yeah, I had no idea. I mean, the IUD to me seems like, you're not, the pill is something that, there's a vulnerability. You can miss a dose. It has all these systemic effects. So yeah, I mean, it's definitely very valuable information that you just shared. There's this lore with regards to fertility that male sperm swim faster. And so there's a way to sort of time conception so that you can, in essence, pick the gender.
Right.
Is there any truth to that?
Not really.
No.
I mean, you'll be right 50% of the time.
50% of the time.
But there's been all these things that have been floated about like spinning sperm a certain way, like putting them in a centrifuge and being able to do inseminations in a way that influences male or female. There are some studies that show like 80% accuracy, but in our experience, there is no truth to any of that. The one way that you can potentially influence the sex of a future baby is if you're going through IVF and you genetically test embryos and you know that information, because we often will count the number of chromosomes, and obviously the sex chromosomes determine male or female sex, right? There are countries like Canada and the UK where you're legally, as a fertility doctor, not allowed to disclose that. I mean, The labs that do that analysis on the embryos, the cells that are removed from an embryo and sent out for testing, are legally not even allowed to disclose it on their reports. So even if the fertility doctor wanted to know, they don't have access to that information. Here in the United States, that is not a law. And depending on the clinic you go to, I mean, every clinic will disclose. Now, whether you're able to choose on the basis of sex is kind of more clinic dependent and something that's like a hugely debated topic when it comes to ethics. But in my clinic, in my practice, if a patient has 2 high quality embryos and one is male, one is female, and there's no difference between them in terms of their chance of success, I don't mind if they have a sex preference personally.
Is standard of care in IVF still don't they implant more than one embryo?
Not nowadays. Not if you're at the cutting edge of how things should be practiced. I mean, the guidelines state that if you have a genetically tested embryo, those have very high reproductive potential. So there's very little justification to put back more than one at a time. If you have a high quality, we can grade them based on how they look under the microscope. We can confirm, hey, this embryo has 46 chromosomes, 23 from the egg, 23 from the sperm. Therefore, it has about a 60 to 70% chance of live birth. That's the best we can do, right? But if you have 3 frozen embryos, you know that your cumulative probability with 3 different attempts is about 92% live birth rate, which is really good. So if I put in 2 at a time, I'm not really helping your success that much. The overwhelming effect is going to be a very increased risk of having twins and sometimes triplets because one of those embryos could split. That happens at a slightly higher rate with IVF versus just what occurs naturally. Naturally, it happens like less than 1% of the time that an embryo splits into identical twins. With IVF, it's more like 2 to 3%.
Wow.
Yeah. So we only put back 1 at a time, honestly, like 99% of cases. If someone says, I don't want to do genetic testing on my embryos, which there's a lot of reasons why they might come up with that. There can be an added expense associated with this technology. And if you are paying out of pocket, that might be a reason, which I hate that as a reason because I want the medicine to be dictated by the medical recommendation, right? But sometimes patients have a hard time getting those eggs to grow into embryos like we talked about earlier. And so there is this idea of, well, even if it's slow growing and hasn't separated out into 2 cell types that facilitate us being able to biopsy an embryo safely for genetic testing, maybe the best we can do is pivot to plan B and say, let's put back 1 or 2 embryos, depending on your age, maybe 3 embryos, because we know some of them might be abnormal and we don't have that information. So when you're not doing genetic testing, if you're over 38, it is permissible and medically still considered responsible to put back 2 embryos, because at that point, there's a 50% chance an embryo could be abnormal. So you're kind of counteracting that by putting back the 2 fastest growing ones.
And how often does that lead to twins? It's
so variable because it's hard to know what we're working with quality wise, but I would say, it could be a rate of as high as 20%. It's risky and it's something that we talk about. I think the bigger risk though is we are blindly transferring these embryos. And if you're someone who's had a long-standing history of infertility or even recurrent miscarriages, I don't know that I'm not helping you control for that because now I don't know the status of these embryos. So the risk of miscarriage might be very high, especially in a patient who's, in their 40s.
Wow. What are the biggest fertility myths circulating on social media that you wish would just die?
I think anything where it's like too good to be true. Like if you just have this tincture or you take these supplements or you follow this really specific prescriptive formula, you are going to overcome your infertility. Like that type of like marketing gimmick, that's probably the biggest myth that I think is the most damaging. It veers people off course. It gives them false hope. And at the end of the day, the people delivering that message are often non-experts. And even the ones who are experts, they're overreaching because they think that they're telling the listener or the viewer, whoever's like consuming that information, what they want to hear, right? And it does feel soothing at first. Listen, you're like, oh, okay, you're just going to tell me what to do? Like, I don't have to think about this. I'm just going to follow this and take these supplements. Great. But the backlash of it all, when all said and done and like the dust settles, is, oh, well, I'm in this position. I'm having recurrent losses and infertility because I wasn't doing all these things. Oh, shame on me. Like, I should have found this information sooner. And it's like, no, that's very magical thinking. There's many, many causes of infertility that are completely not your fault, not because of something you did or didn't do. A lot of it can be determined by genetics, environment, and bad luck, right? And the best we can do is we can say, all right, here are the lifestyle things to focus on so that you're bringing your A game, right? But let's be honest and real that that might not be enough to overcome everything in and of itself. You should be doing that concurrently with relying on medicine and science if needed. So I think there's too much of that narrative right now online, and I see the harm of it. I see women feeling like they need to live in a bubble and feeling a lot of self-blame and shame around their infertility. I think another big one is, just the focus being disproportionately on women. And we talked a little bit or a lot about male fertility. And I think we are past the days where the male partner says, I don't want to get tested because it's probably her. That used to be a thing. I feel like we're getting past that as a society in most cases. But now we really need to be focusing on both partners, not smoking, and both partners controlling their chronic hypertension or whatever medical issues, both partners showing up, because I think the emphasis has so traditionally been on the female partner because she's carrying the pregnancy most often. And it just feels like, well, this is more dependent on your body. But meanwhile, what about the male role in the placental function and all the things that we were talking about?
Super interesting. Should couples, should each partner get individually tested and assessed prior to attempting to conceive?
That's a good question, and I don't think there's anything wrong with it. Is it practical or necessary? Maybe not, right? I don't know that everyone needs to do a semen analysis because I don't know that it's dangerous if they have a slightly low parameter and they get someone pregnant, right? I think it's more holistically thinking, do I know I'm doing something that I shouldn't be doing? Are there things that I could be controlling better in terms of my health? And we should be doing that all the time anyway, right? Not just for this, but definitely taking stock in that before you're getting on the journey to getting pregnant and pregnancy health, thinking about pregnancy health and all of that. The one caveat is, and this might be controversial because as doctors, we're supposed to follow guidelines. There is no guideline that states before you get pregnant or try to get pregnant, you should have at least one pelvic ultrasound. But I'm a big believer that there is a rationale for that. Sure, if everyone got a scan at least once in their 20s or 30s, would there be a lot of people getting unnecessary scans? Maybe, with normal results, right? But I, as a fertility expert, am, I think, at way too high of a frequency being the one to tell someone, hey, you have fibroids. Or, oh, you have a big endometrioma, like a cyst that is in your ovary taking up all the space, and it's been there probably for a while, growing insidiously in the background. Oh, you were born with a uterus that has a wall down the middle, and you were born that way, and this could be a major cause for fertility issues, in particular, recurrent pregnancy loss. And a lot of times these are things that are being worked up after the fact, when the problem has already occurred. And I see, the look on my patients' faces when they're meeting me for the first time, and at the end of the consultation, I'm like, let's go do a scan. And I'm telling them this for the first time. There is a look of, why didn't I know this sooner? I feel betrayed. I feel upset, frustrated. And it's also not fair. There are some patients, I always ask before I do the scan, I'm like, have you ever had this done before? It's a vaginal ultrasound, right? So maybe it could be viewed as invasive, but I always say it's easier than a speculum exam, and everyone gets those done for their pap smears, right? And I just think that it can give you an insight that just a physical exam, laying your hand on someone's abdomen, you're not going to be able to tell. We don't have x-ray vision, right? And there could be things that if you knew about them, you could get ahead of it, or at least have an awareness, right? If someone knows they have fibroids or they know they have any sort of major gynecologic issue, then it's a really smart idea to get re-imaged before you start trying. Because how do you know that the fibroid that was 2 centimeters deemed not a problem 5 years ago hasn't grown, hasn't made its way into the inner lining of the uterus where it's taking up valuable real estate and could put you at risk of a miscarriage after, a hard-earned pregnancy is finally conceived? It's like, how frustrating would that be to not look into that ahead of time? So I actually think that's the one thing that I would say I want to see a change, because I think some people have a GYN that will do an occasional ultrasound here or there. And then some people are like, I'm 40 and I've never had one.
At what age is that ideal? What do you call it, pelvic ultrasound?
Yeah, a transvaginal ultrasound or pelvic ultrasound. Listen, I don't have all the answers. I would say, just based on my experience, what would I want for my daughters? I have an 8-year-old and a 5-year-old. I would like them to get an ultrasound in their 20s. I'd like them to know well before they're even thinking about having kids if there's any issue. I want to know.
And what are the most common issues? You mentioned fibroids. What are those?
Fibroids are benign tumors, benign growths that are in the muscle wall. Your uterus is like this triangular shaped organ, and the main purpose is for it to hold a pregnancy, right? And that's the lining that builds up and sheds when you get a period. And it's surrounded by muscle. The wall of it is all made up of muscle. And sometimes you can get a cell within that muscle that for some reason just keeps proliferating. But it's a benign tumor, right? People get so scared by the word tumor, so I barely ever use the word tumor. But that's what it is. It's a benign growth. And they're like these whorls of like muscular tissue that are very easy to distinguish from the regular surrounding muscle on a pelvic ultrasound, on an MRI. But you don't need to do an MRI. You'll see it on an ultrasound. And if it's on the outskirts, if it's not pushing on that inner wall and taking up space, then it's usually not a problem. Up to 80% of women will have fibroids in their lifetime. Super common. Definitely much more prevalent in certain populations. Like Black women have a much higher rate of fibroids, and we don't really understand why. It's been linked to potential vitamin D deficiency and things like that, which is really interesting. There's definitely a genetic component. And they can cause really heavy periods, pelvic pressure and pain. And if they're on the inner lining, like if they've eroded into the lining, they are a cause of infertility and pregnancy loss. And if they're big, but not in the inner lining, but deforming the cavity, that's a reason to get surgery too. And it can lower your risk of these complications.
So they're treatable.
They are treatable. It can be really difficult, especially in women who have a lot of fibroids or very large fibroids. The surgery itself can cause complications. So, and they can keep coming back. So some people have really difficult cases. And then there are some patients where it's like they have one solitary fibroid, they get it removed, end of story. They go on and they have great healthy pregnancies. So no two cases are exactly the same. Sometimes they get an MRI because it's easier to kind of globally see how it's affecting the architecture of the uterus. And it's really important to get an MRI for surgical planning. If you're going to have a surgery, that's the only way to really see where everything is.
What are the other components of what I guess you would call a basic fertility workup?
Well, the basic fertility workup, if someone comes to me and they're actively trying to get pregnant, it's not happening, I think of the 4 components of what it takes to get pregnant, right? You need ovaries and the eggs they contain. You need the fallopian tubes where the egg gets released into. That's the meeting place for the sperm and the egg. You need a nice smooth uterine cavity for an embryo to actually implant, and you need sperm, right? So semen analysis, that's one. Check it off the list. The other is, you can look at the tubes. One of the most commonly used tests for this is kind of like a 2-for-1 test. It's called an HSG, a hysterosalpingogram. It's an X-ray of the pelvis done by either a fertility specialist or a radiologist. They lie you on the table, they put dye through the cervix, and they watch it kind of fill the uterine cavity and spill out of either tube. And in that moment in time, they take a bunch of x-rays and the dye lights up on the x-ray. So it's the one way to really show that there's functionality of the reproductive tract and there aren't blockages. You don't always see those blockages on an ultrasound. And then the ovaries, I care that you're ovulating. There's hormone tests that we can do dynamic throughout the menstrual cycle to confirm that you're making enough progesterone. We can check your AMH level, anti-Müllerian hormone. That's a marker of your egg count. Not really a fertility test, but often marketed. It's like one of the many myths that I talk about, right? Because there are companies that will say, we can test your fertility. Like, send us a drop of blood and we'll tell you your AMH. At the end of the day, all it's telling you is your egg quantity at this snapshot in time. Why is that not actually a fertility test? Because every month you only ovulate one egg. So whether you have a high quantity or low quantity is not going to influence your fertility or ability to get pregnant. But I still care about it because if someone does need treatments like IVF or they're going through an egg retrieval cycle to freeze their eggs, then the number that I have access to can dictate how many eggs I'm going to get from one round of effort and the efficiency of the treatment. So that's at a high level. And then obviously there's things like thyroid function, like other hormone tests that indirectly can impact ovulation and fertility.
Yeah, I do want to ask about the blood biomarkers, but going back to the x-rays, are there risks associated with that, like x-raying the pelvis?
It's a really minimal, I would say it's a very minimal exposure to radiation, and it's not generally something you're going to need to do over and over and over. Like if someone's had a normal HSG test within the past year and it's not like they ruptured their appendix or had multiple abdominal surgeries or a new diagnosis that makes me think, hey, we need to re-image. It's not something you're getting exposed to time and time again, but it can give you a lot of information. And I will say this is often something that gets skipped when people go straight to IVF for whatever reason. And they think, oh, well, I'm bypassing the tubes. We're taking the eggs out. We're putting the eggs and sperm together outside the body, growing them into embryos, putting an embryo in vaginally into the uterus. Why do I need to know if my tubes are unblocked? Because your tubes are part of that environment and they're in direct communication with your uterus. And if you have an inflamed fallopian tube from an old infection you had no idea about, or from conditions like endometriosis, that can lower your chance of an embryo implanting by 50%. It can double your risk of miscarriage. So I've had patients come to me from other clinics. They're coming to me for a second or third opinion. And they're like, I just don't understand. I have these beautiful embryos. I keep having miscarriages. And I'm like, did anyone look at your tubes? And we'll do this test. And I'm like, oh, it's not always the answer, but sometimes I find out that it's the answer. And those patients are hugely frustrated that that could have been avoided.
Oh, wow.
Yeah.
Very interesting. What about blood biomarkers? Are there any blood biomarkers that are more closely related to better or worse fertility?
There's no biomarker for egg quality. And that's really what I would argue is the most important factor when you think about egg-related factors. But, you know, biomarkers like estrogen and progesterone are telling you about what's happening at the level of the ovary, because those are hormones that are produced by the ovary, mostly estrogen in the first half of the menstrual cycle. Once you ovulate, then your progesterone levels, rise. And so checking progesterone roughly a week after you think someone ovulated. So if someone has a 28-day cycle, like on day 21, I want a level above 3 to confirm ovulation happened. If someone's actively trying to get pregnant, I might supplement progesterone if the level is less than 10, just to make sure I'm giving all of the support needed. In terms of the AMH level, the level that's considered normal for your age, like do you have a normal egg quantity for your age? It depends on your age, right? So what's normal for 40-year-olds is not normal at 20 and vice versa. There's actually a great study where they looked at around 17,000 women who didn't have infertility, but they just came in to get their AMH levels checked. And it created like a normative curve where people could say, okay, well, this is now where I fall. This is what the average is, but the standard deviation was so huge. So there's a lot of variation. And listen, there's a lot of women outside on the sidewalk walking around with no known fertility issues. Maybe they've had a bunch of kids and they might have really low egg count and just not know about it because they didn't check it. So, take it with a grain of salt. But if it is low or in an unexpected range, then maybe that will prompt further testing to look at genetic risk factors for going into early menopause or things like that. But I wouldn't let yourself feel labeled by a low egg count, right? Because at the end of the day, it doesn't predict your fertility. Your biomarkers from your pituitary, a lot of people don't realize your brain plays such an important role in all this. So follicle stimulating hormone, luteinizing hormone, these are the signals that get sent to your ovary from your brain to tell it to select randomly, like a lottery, one egg to mature and then ovulate. So when people pee on those ovulation predictor kit sticks, what they're actually seeing is the LH surge, which is the secondary signal once you have an egg that's ready to ovulate, and it gets filtered into their urine very quickly. And so it kind of gives them a warning sign of, hey, in the next 24 to 36 hours, you're going to ovulate. So now's the time to try.
So interesting. God, we're so elegant, so complex, so elegant.
Yeah. There's magic happening in our bodies.
It's beautiful. What an incredible thing. What about for men, like testosterone levels and stuff like that?
Men have FSH and LH in their brain as well, right? So those same markers that I'm talking about in the female brain exist in the male pituitary. And instead of driving things like estrogen and progesterone production, it's actually more so driving the production of testosterone and sperm production. So both of those signals are important for sperm production and proper testosterone production. What's interesting is every once in a while I come across a couple where either the male partner is forthcoming or not, but, maybe on testosterone supplementation. And you would think that's going to boost sperm production because you do need a healthy level of testosterone. But what's interesting is it's actually a paradoxical effect where it kind of shuts the signals off, similar to it's like a male birth control. You know how I said birth control shuts those signals off so you stop ovulating? And so that stimulus is no longer there, and it actually can lead to lack of or zero sperm production.
Wow.
And it's not always reversible.
It's not.
It's not always reliably reversible.
Damn. I mean, I have so many peers at this point that are on TRT.
Yeah.
Does it matter which level you are pushing your testosterone to? Is it like only for super physiological levels, or is it?
I would say I've seen this effect with people doing what they thought was a low dose as well. Like, it's not something I would mess around with. I think that is a major PSA that men should know if their future fertility is important to them to not mess with TRT.
Wow, that's great to know.
Yeah.
That is really good to know. Because, I mean, is it people are, I feel like, especially like in the wellness, fitness space,
100%.
the fitness space in particular, like
Yeah.
people are like taking, I mean, don't even get me started on peptides, but like testosterone, like it's creatine, like it's the new creatine.
I know, it's scary.
Wild stuff. Well, anything else that people ought to know? I mean, it's such an important topic, and it's like so hard to, it's like finding a needle in a haystack today, finding good quality evidence-based information. That's what we aim to provide here on the show. So anything else that people need to know that you feel like is being underserviced?
I mean, I think that there's a lot of preconception planning that people don't think about. They don't do. I think treating your period as a fifth vital sign and really paying attention to, is your cycle irregular? Is it heavy? Is it painful? That might prompt earlier conversations with your OBGYN that lead you down a path of diagnosis. I love my colleagues. I'm not a doctor that bashes other doctors. But I think we have to get away from this model where there's this paternalistic model of healthcare where, women, patients don't ask questions, because we see time and time again that there's a gross chronic miss or underdiagnosis of certain conditions that we know can have a long-term impact on your quality of life, your health overall, and your fertility, right? And so I think that we are treating fertility very much like on a need-to-know basis. And then, we're talking out of two sides of our mouth because we're saying like, well, don't worry about it until like you're there. But at the same time, not to sound dramatic, I do think we have a fertility crisis in this country. I don't necessarily, think of it along the lines of everyone needs to be having more babies at a younger age. But I think there's a misinformation crisis. I think there's an ignorance crisis. And I'm not blaming anyone for that. It's like we were set up to fail. We were taught this information with a major focus on how to contracept, which we've done a great job at, because now we're, for the first time in society, we have more women getting pregnant in their 40s than teen pregnancies, okay?
Wow.
Yes, that is a real statistic. But knowing what you need to know about your reproductive health goes so far beyond contraception. And the age we are when we are taught some of these topics, like how the menstrual cycle works, we don't have the level of sophistication to truly understand why this is important. And then it's never revisited. And then the information that you have at your fingertips is kind of like a matter of luck, hence the title of my book. Like there's so much that comes down to luck, which shouldn't. Like, do you have a good OBGYN that happens to take the time to counsel you and maybe says, hey, let's go one step further and do at least one pelvic ultrasound, right? Do you have a friend group or family members that provide you with helpful, cautionary information about the biological clock? We are the first generation that have entered the workforce. I'm so grateful to be, I have opportunities that my mom and my maternal grandmother never had, but it's such a challenge that we've been thrust in this generation into the situation where, okay, now we're competing on equal footing and trying to get all of our aspirations and do all the things. But also, magically, we're supposed to do a 180 at one point and then know what to do and know what the biological clock means and know how to track our ovulation. And being left to our own devices has led to the place that we're at right now, which is a lot of women feeling nervous, afraid, anxious about their fertility, kind of racing against the clock, maybe showing up a little later than what would be ideal to even consider things like egg freezing. And I just think that we need to be having these conversations earlier. I'm not a fertility doctor that's like, everyone should freeze their eggs. But I do think everyone, no matter how much they feel compelled that one day they're going to want to be a mom or not, you can change your mind. And I think it's really important to think about what your priorities are. And I know it sounds silly, but we're all on this like hamster wheel of life. And it's really easy for the time to pass us by and then for us to say, oh my God, but this was really important to me. And I wish I just had spent more time and effort considering my options and understanding what I needed to know.
Wow, beautifully put. Do you think it's within the realm of biological possibility that one day that window, that prime reproductive window, might be extended?
It's possible. I definitely think, the science could be there. There's a really interesting scientific study that came out recently that was talking about, is there a way to counteract this breakdown in the machinery that happens in our eggs? And specifically, it's that protein called cohesin. And they found a very specific protein that they were able to engineer that seemed to lead to eggs having less of those breakdowns. This was in like the mouse model. And then they looked at it in human eggs too, but none of these human eggs were actually used to create embryos to get anyone pregnant. So I think we're still far from prime time. But I think certainly if we get to the underlying cause of where these breakdowns happen as it relates to aging, for sure we could probably help, stem that effect and try to push the needle a little further. I mean, look at IVF. The IVF is a workaround. It's not actually getting to the root issue. But the fact that now we can say, all right, I have patients who at 45, where they traditionally have a 90 to 95% chance of an embryo coming from their egg, whether it's ovulated or extracted and, turned into an embryo in the lab, 90 to 95% chance of having chromosomal errors. That's one of the reasons why it's the main driver of why it's so hard to get pregnant. And there's a higher risk of miscarriage at that age. But I've had patients where we've been able to extract multiple eggs, grow them in the lab, turn them into embryos, test them, and maybe one comes back normal and the rest that aren't normal, we're like, let's not use those. And we can, in a focused fashion, use that one embryo to help them get pregnant. I mean, could they have ovulated that egg on their own? Yes, because everyone still has normal eggs, even in their mid-40s. But it's like a needle in a haystack. And so that's why I called my book The Lucky Egg, because I wanted to illustrate that while science has gotten us very far, and we can do those types of miraculous things that really streamline someone getting pregnant and lower the risk of miscarriage that they otherwise maybe would have experienced if they had just done this on their own, there are also many people that can do this on their own. Maybe we don't rely on it statistically, right? But we have to kind of leave open the possibility for miracles and the role of luck, because it ain't over till it's over. I say that to all my patients, right? There are people we all know that have failed IVF or had, things not work out when we tried to control every aspect, and then they were able to ovulate a healthy egg. It's not something you count on, but I think that we have to be open to that possibility. And as doctors, I think if we place too much emphasis on science and, we can control it all, that's not true. We can't guarantee that IVF for sure will be successful for every patient. We can give you information and make, an educated guess. But at the end of the day, all it takes is one lucky egg.
All it takes is one lucky egg. The Lucky Egg. Thanks for coming out. I've got one last question for you, but before we get to that, where can people pick up the new book and where can they find you on social media?
The book is everywhere. It's everywhere worldwide. You can get it online in any bookstore. You can find me on social media. I'm most active on Instagram at lucky.sekhon, Sekhon. I'm on TikTok at Dr. Lucky Egg, and I have a website, theluckyegg.com. This is where I have a lot of interactive tools. For instance, you can put in your age and your AMH, and it will plot you on that graph with the 17,000 other women so that you can kind of see where you stand and contextualize some of these concepts.
Fun. Well, the last question that gets asked everybody on the show, what does living a genius life mean to you?
I think what that means to me is being present, really like keeping your big picture long-term goals at the forefront of your consciousness in everything that you do. And I think that's hard to do. I think it's very easy to get distracted by the day-to-day minutia. But I think people that really keep their eye on the prize, some people call it manifestation. I think it's just really keeping, your eye on your goal. And something my husband does that I've really tried to adapt, because I think it's fantastic, is he writes down his long-term goals and his monthly goals, and he just keeps it on a piece of paper on his desk. So it's always there. And I think that's brilliant, because it's very easy to say, I want to write a book. And then you're not thinking about it in your day-to-day. You're just in survival mode. And I think so many of us are stuck in survival mode that it's really important to keep your long-term vision at the forefront so that you don't kind of get swept away and forget about the things that are most important to you.
No, it's so true. So many people want the wins, but they don't necessarily want to do all the things that it takes to get to those wins, especially, and social media makes it incredibly difficult today, because you see months, if not years of work today compressed into a carousel, like a before and after photo.
Yeah.
And it just, it doesn't make things any easier.
Absolutely. I agree.
Well, thanks for coming out.
Thank you for having me. This was a great conversation.
So fun. Thank you guys for listening. Share this with people in your life that you think may benefit from it. And pick up the Lucky Egg. I will catch you on the next episode. Peace. Hey, if you liked that video, you need to check out this one here, and I'll see you there.